Let me take the honor of introducing the next speaker. He doesn't need any introduction to the Haemato-Oncology fraternity in the world. Let me briefly introduce him to you. Professor Charles Craddock is the academic director of the Center for Clinical Hematology at the Queen Elizabeth Hospital in Birmingham, and the professor of Haemato-Oncology at the University of Birmingham. He is trained in hematology at the Hammersmith Hospital, London, the Institute of Molecular Medicine at the University of Oxford, and the University of Washington, Seattle. So he leads many academic bodies and research bodies involved in bone marrow transplantation and hemato-oncology in the UK. So without any further ado, Professor Charles Craddock, ladies and gentlemen.
Well, good morning. I'm very grateful to the organizers for the honor of presenting at this important meeting. And I particularly want to express my gratitude to my great friend Davinder, who I hugely enjoyed working with at Queen Elizabeth Hospital in Birmingham. And I remember giving him some unique leaving presents, which I hope that Davinder has enjoyed listening to. We could possibly discuss what those were in the Q&A. So I've been asked to talk about acute myeloid leukemia and the most important and effective treatment option in adult acute myeloid leukemia, which is stem cell transplantation. These are my disclosures. I wanted to remind you that the outcome for adults with acute myeloid leukemia with current chemotherapy and transplant options is very poor. Only 40% of patients over 40 are destined to have long-term survival. And that percentage drops off very significantly in patients over the age of 65, partly because there's a challenge in delivering intensive chemo to this population, but also because of increasingly adverse biology and complex genetics. So just before we launch into thinking about treatment modalities, I think it's useful to discuss some really important advances in terms of risk stratification, in terms of prognostication in adult acute myeloid leukemia. This is really important, of course, because to advise a patient how likely they are to achieve long-term survival with intensive chemo is an important part of the educating process. It also assists us in identifying patients who have a poor outcome, as I'll discuss in a minute, who should be considered for transplant, and increasingly identifying, as we'll discuss in a minute, molecular abnormalities, identifies potentially druggable mutations. So the MRC categorization of favorable and intermediate and unfavorable risk has stood the test of time. And we know that core binding factor abnormalities and APML broadly have a very good outcome with intensive chemotherapy, but that there's a large population of patients with complex karyotype or abnormalities of chromosome 11, 3, and chromosomes 5 and 7, whose outcome with intensive chemotherapy is very poor. What's happened in the last 5 years really has been our ability to use next generation sequencing and then exomic sequencing to demonstrate that over and above these cytogenetic abnormalities, there are multiple mutational abnormalities that are detectable at diagnosis in AML, and importantly, that these mutational abnormalities can have prognostic significance. So these are the refined data of the green line at the top of this curve. And I also talked about cytogenetic abnormalities associated with the very poor abnormalities. Chromosome 3 abnormalities, complex karyotype, chromosome 5 and 7 abnormalities, where the outcome is as bad, if not worse, than pancreatic carcinoma. What's happened in the last few years has we've been able to use genetic stratification to dig into that large population of patients in whom we don't determine a cytogenetic abnormality. And just using mutations in FLT3, in NPM1, CBP alpha, RAS, and MLL, it's possible to subsegment this group of patients with intermediate risk cytogenetics, usually a normal karyotype, into relatively good risk patients, NPM1 positive, FLT3 negative patients, or high-risk patients, patients with FLT3 mutations and a high allelic burden. And of course, now we can combine the prognostic significance of cytogenetics and molecular abnormalities, and we're finding that we can be much more precise in terms of predicting outcome and particularly relapse risk in fit adults treated with intensive chemo. Just have a look up here. These are patients with a biallelic CBP alpha mutation who do extremely well with intensive chemotherapy. And look down here, patients with a TP53 mutation in the context of a complex karyotype, an extremely poor outcome treated with intensive chemo. And so, as I say, we can integrate cytogenetics and mutational risk profile, come up with an increasingly sophisticated strategy of identifying relapse risk in patients treated with chemo. And this, I don't want you to read all this, but this has informed the development of the WHO classification, which now defines AML in patients with particular cytogenetic or molecular abnormalities on the left, and also patients who have secondary AML, treatment, therapy-related myeloid neoplasias as well. And it's possible now, of course, to have a nice algorithm picking up the WHO classification in a newly diagnosed adult with AML. Had they had prior cytotoxic chemotherapy? Yes, well, they've got treatment-related AML, therapy-related AML. Do they, if they haven't got a history of cytotoxic therapy, have recurrent chromosomal or molecular abnormalities? Well, yes. And here, as you can see, are the particular WHO classifications on cytogenetic or molecular grounds. T821 in version 16, PML, RARA, APML, and abnormalities associated with inversion 3, and a number of others. Okay, so they don't have a recurrent chromosomal or molecular abnormality. Do they have a history of prior MDS, myelodysplasia, or myeloproliferative disease? Or do they have myelodysplastic related cytogenetic abnormalities? Or on the bone marrow aspirate, more than 50% of cells showing evidence of multilineage dysplasia? Well, if they do, then they go into a category, according to the WHO, AML with called MRC. Otherwise, they have fall into the WHO AML NOS criteria, which is defined here. So we're good now at defining these subgroups of patients who have particular molecular abnormalities, or we can lump into therapy-related or MRC, AML. And this is important because it's not the subject of this talk, but of course drugs such as liposomal daunorubicin and cytosine ribnoside, Vyxeos, show particular benefit in therapy-related AML or AML associated with MRC features. The other risk stratification which people find increasingly valuable was developed by the ELN group. And again, this uses mutations, cytogenetic abnormalities to pull out good risk patients. We've talked about biallelic mutated CBP alpha. We've talked about isolated mutated NPM1, but these patients also seem to do quite well with a FLT3 ITD mutation as long as there's a very low allelic ratio. And also we talked about these CBF abnormalities, T821 or inversion 16. So there's your good risk. And then we can equally identify patients with the cytogenetic abnormalities I previously talked about, but now with mutations in TP53, ASXL1, RUNX1, isolated FLT3 mutations with a high allelic burden, who have a very poor outcome. I think this is important, this classification, and actually operationally, I think we use it more than the WHO. It's partly because it's quite easy to apply, but also increasingly, you can use it to pull out potentially druggable mutations. You've got a FLT3 mutation. The evidence is if you apply midostaurin along with DA induction chemotherapy, you're going to do better. If you've got relapsed FLT3 positive AML, there's good evidence for the Admiral trial that gilteritinib is better than intensive salvage chemotherapy. And similarly, there are new agents being delivered other targetable mutations. So just to conclude this part of the talk, we're getting much better in fit adults under the age of 70 or 75, in stratifying patients into good risk or high risk. So patients who have favorable disease, they at the moment receive 7+3, DA7+3, and there's evidence that gemtuzumab ozogamicin, CD33 conjugate, improves outcome. So that's how we treat patients with a CBF abnormality, 7+3 plus gemtuzumab in the first course. And we try not to take these patients to transplant because they do well with this treatment. In patients who've got a FLT3 mutation, I've talked about the importance of midostaurin, and we would consider most of these patients for transplant. Patients with secondary AML, we've already discussed the CPX351, the liposomal form of DA is associated with improved outcomes compared with DA induction chemotherapy. So that's the treatment of choice. And in patients with interim or adverse risk disease, we're really focusing just on getting these patients into remission, and these patients are considered a priority for allogeneic transplant. And we're going to talk a little bit in a minute about who we choose patients for transplant. Just wanted also to draw your attention to the fact, although we say that DA induction chemotherapy is standard of care in fit patients, remember the impact of age, comorbidities, performance status, and cytogenetics. So in patients who have a poor performance status, the treatment-related mortality of DA induction chemotherapy can be north of 20%. So this is quite toxic therapy. In younger patients, it's much easier to deliver. The toxicity increases in patients who have an adverse karyotype, and the CR rate falls off. And it's not the subject of this talk, but you'll be aware of the VIALE-A data in the New England Journal last month, which shows very promising results in terms of CR and in terms of survival compared with azacitidine, the venetoclax with azacitidine. And it's my belief that particularly in patients with poor performance scores, we're going to be increasingly thinking about using VA as a strategy to get patients into remission rather than DA induction chemotherapy. So this is really a summary of where we are with treatment strategies. And I want to remind you really that although there's been significant advance in treatment strategies, and that a significant number of patients we've identified which subgroups they are, the favorable subgroups, can achieve long-term survival with induction chemotherapy, DA, plus or minus other drugs against druggable mutations. The majority of patients over the age of 40 with AML treated with intensive chemo will relapse and die. So we have to think about how we address that. And this is where stem cell transplantation comes in. So we know that our ability to find suitable donors is steadily increasing, increased availability of adult unrelated donors, but increasingly the use of haploidentical donors. So identifying donors is easy. Toxicity of transplant is much less than it was, partly because of better supportive care, partly because of better GVHD prophylaxis, but also critically because of the introduction of reduced intensity regimens. So we're now in a position where we can think about a transplant in the great majority of fit adults with what we deem to be high-risk AML. And why is that important? Well, it's because allogeneic transplant exerts the maximal anti-leukemic effect in adults with AML in first remission. And how do we know that? Well, some beautiful studies by the HOVON group looked at adults with AML in first remission who either received intensive chemotherapy alone or an allograft. And critically, for the purpose of this discussion, I want to focus on the relapse reduction with allogeneic transplant. The hazard ratio for relapse was about 0.35. That's about a 60 to 65% reduction in the risk of disease relapse. If you have AML and you're in CR1, and you go to transplant rather than just receiving chemotherapy. That's a dramatic reduction in relapse risk. So we'd like to therefore deploy a transplant in any patients we deem to be high risk. So I want to spend the next few minutes just thinking about, well, which of those patients should we choose? And this is a much easier calculation now than it used to be. It's a calculation, as Devinder will remember, that I used with colleagues have to make on every Monday afternoon in our new transplant clinic in Birmingham. And there are two considerations in this dynamic assessment. The first is, if we just treated this patient with chemotherapy alone, what is their likelihood of relapse risk? So we can determine that on the basis of mutational abnormality or chromosomal abnormalities. We can also increasingly look at MRD status, as I'll touch on briefly, after chemotherapy as a predictor of relapse. And the other critical determinant is, how safe is it to deliver the transplant? What's the likelihood of 1-year transplant-related mortality? Well, this is determined by age to some degree, but mostly by comorbidity. So let's deal with comorbidity first. That's quite easy. So this is American data showing if your score using an HCT-CI, hematopoietic stem cell transplant comorbidity score, if it's 3 or more, your outcome from transplant is dramatically worse than if you have no comorbidities, and that's because of increased in transplant-related mortality. So for those of you who are not familiar with the HCT-CI, this is easy scoring. I did it 5 times yesterday afternoon in my clinic. What you do is you look at patients' renal function, cardiac function, pulmonary function, and their history of other significant comorbid diseases, and you can come up with a scoring system. So we would be very reticent, there are exceptions, but reticent about taking a patient with a score of 3 or more to transplant. This is particularly relevant as we now start transplanting people over 60, and this is some UK work we led from Birmingham, showing that if your score was more than 1 and you were 60 or over, your outcome of a reduced intensity transplant was dramatically worse, and that was because of very substantially increased transplant-related mortality. So I said to you that it's easier now to pick which adults with AML in remission should be considered for transplant, and I'm going to try and persuade you and give you an outline about how to do this. So what we know is that you more than halve the risk of relapse in patients treated with a transplant. So let's just for a moment start with a patient who is good risk if treated with chemo alone. They've got favorable risk characteristics, maybe NPM1 positive. Their MRD after 2 cycles is negative. And what's their risk of relapse if just treated with chemotherapy? It's about 30% possibly. So we're going to reduce that risk of relapse. We will with a transplant. We'll about halve it. So that's a benefit to the patient because their risk of relapse goes from about 30% to 15%. But of course, the transplant-related mortality at a year, even with a well-matched donor and a fit patient, is about 10 to 15%. So any benefit in reducing the risk of relapse is outweighed by the toxicity of the transplant. So we wouldn't recommend transplanting patients with favorable cytogenetics or molecular features or favorable MRD in the setting of NPM1 positivity at all in first remission. On the other hand, if these patients are MRD positive, NPM1, MRD positive after 2 cycles, or if they have intermediate risk disease, their risks of relapse if treated with chemotherapy alone range from about 50 to 75%. So let's go through the maths again. You're going to more than halve the risk of relapse. So you'll come down from, let's just say for the sake of argument, 60% risk of relapse. You're going to more than halve that. So the risk of relapse comes down to say 25%. So that's a 35% benefit to the patient, 35% overall reduction in risk of relapse. If you can deliver the transplant with a toxicity in the region of 15 or even 20%, the patient's clearly going to benefit. So that's easy. Patients with a relapse risk of certainly more than, in our judgment, 45% should be deemed as allomandatory. They should, if they're fit and have got a good donor, go to transplant. And what I also want to draw your attention to is that patients with unfavorable characteristics, particularly patients with adverse cytogenetics or adverse molecular features, can have a relapse risk even higher, maybe as high as 80% if treated with chemotherapy alone. So you go to transplant, you reduce that relapse risk by more than a half, say bring it down to 30%. That's a 40 or 50% benefit to the patients. And in those circumstances, you're prepared to go to transplant if the transplant-related mortality is predicted to be a bit higher, either a mismatched donor or the presence of 2 or 3 comorbidities. So using this dynamic assessment that was initially articulated so beautifully by Jan Cornelissen, I think we can identify which patients with AML and CR should be considered for transplant. And now finally, I want to think about how can we improve transplant outcome. We know that the main cause of failure in patients transplanted is disease relapse. The risk of relapse is much lower than if they have chemotherapy alone, but it's still between 30 and 50%. So the strategies could be, well, we could reduce the amount of minimal residual disease before the transplant. We believe that's important. So we could concentrate on the chemo they get before going to transplant, number one. Or maybe the drugs that we give before stem cells are infused, the conditioning regimen, could be made to have more of an anti-leukemic effect without an increase in toxicity. And then finally, maybe we could deploy this graft versus leukemia effect, we'll talk about in a minute, more effectively. Now let's just go through those options. So I think the role of pre-transplant MRD as a prognostic factor for relapse has been an area of focus for a number of years. And in fact, a number of retrospective studies, this is a study from Seattle, have suggested that if you have detectable MRD prior to stem cell transplant using an allogeneic donor, your risk of relapse is something like 40 or 50% higher than if you are MRD negative. So the challenge with that data, of course, is it's retrospective. And if you're like me, you're very skeptical of retrospective clinical data, and you're also increasingly skeptical of retrospective translational data. So where is the prospective data? Well, we've just completed in the UK and are just submitting for publication a randomized study, which I'm going to come to in a minute, of 2 forms of conditioning regimen. But for the purpose of this discussion, what my colleague Professor Freeman was able to do was to measure the amount of residual disease before transplant and correlate it with outcome. And what Sylvie showed was, yes, indeed, the presence of MRD does predict an increased risk of relapse, but the impact isn't quite as high as previously published. And remember, we talk at MDTs about what do we do about patients who've got MRD before transplant? Should they have more chemo or go to transplant? We don't know the answer to that question, but these data would suggest actually that even if you're MRD positive, you've still got about a 50% chance of not relapsing, and so transplant should be considered in that setting. So in the COSI trial, which we're rolling out through the UK now, follow on from Figaro, for those of you who know your Mozart operas, COSI fan tutte. This study is an important study, and it's asking in patients who are MRD positive before transplant, is there any benefit of giving intensified chemotherapy in the form of CPX compared with conventional holding dose of intermediate dose Ara-C, 10 grams? So then what sort of conditioning regimen should we use? I'm just going to give you one example about whether it's possible to intensify the amount of chemotherapy you give to patients before a transplant, and does that benefit people? So the Germans have developed a very nice sequential regimen, a block of 4 days extra chemo about a week before you come in for your reduced intensity transplant. It's called a Flamza sequential transplant. So in the UK NCRI group, we randomized 244 patients to either a standard reduced intensity regimen, low-dose busulfan and fludarabine, or the Flamza regimen. And importantly, in this first study of its sort, delivered at UK sites, we found no benefit, no reduction in relapse, and no improvement in overall survival. So in the second part of the COSI trial, which is now recruiting, we're looking at another new conditioning regimen. This one including Thiatipa, called in patients who've had a transplant for AML, there's a very powerful graft versus leukemia effect. Well, what do I mean by that? Well, the main evidence is that the amount of cyclosporin you receive in the first 21 days post-transplant in other words, if the post-transplant immunosuppression, the donor T cells, is modest, the risk of relapse is much lower and the survival is better. In patients who have high levels of cyclosporin, whose T cell function is suppressed, the risk of relapse is much higher and outcome correspondingly worse. Those data can only be explained if there's a powerful and manipulable graft versus leukemia effect. So what can we do then? Well, let's think about it. It's going to take a few weeks, possibly months, for that donor immune system, those donor CD8 T cells, to recognize residual leukemia and kill it. So it's possible that the disease relapses after the transplant before the graft versus leukemia effect has become established. So we could think about drugs that push back relapse, just buy time for the graft versus leukemia effect, or alternatively, clever drugs that augment the graft versus leukemia effect. And in fact, there's interesting data now coming out in patients allografted for FLT3 positive AML in a randomized trial that adding a drug called sorafenib, a FLT3 inhibitor, seems to improve transplant outcomes. Small study, and there's further other studies, but this notion that applying drugs post-transplant that have some anti-tumor effect may be a benefit is gaining traction. And in the UK, as well as the COSI trial, we're delivering Amadeus. And in these patients, we're randomizing patients to receive oral azacitidine, CC486, for a year post-transplant in a large 320 patient placebo-controlled trial. We're doing that through a transplant trial network we've established in the UK, 10 funded transplant centers, 12 satellite centers, and a central hub in my hospital in Birmingham. The hub sets up trials with gifted UK investigators, and the funded research nurse network drives recruitment. We're now in a position where this is becoming a mature network. We've got 5 open trials, and we've now randomized more than 300 patients. And I just want to draw your attention to our first trial, which was a randomized study of donor lymphocyte infusion post-transplant, the first such study that's been completed. This study was really struggling to recruit. There was no network. We opened it in the Impact network across the UK, and look at that red curve. Recruitment explodes, and it closed early. So in conclusion, in fit adults with AML, we want to go for cure with minimal toxicity. So we want to identify patients who will benefit from intensive chemotherapy alone. We can do that on age, performance status, and disease biology. And increasingly, we can use measurable residual disease as a guide. We also need to identify early on patients whose outcome with chemotherapy is not going to be good, who've got a high risk of relapse, who, as I've explained, will benefit from that substantial reduction in relapse conferred by an allogeneic transplant. We need to think about which patients those are. They're patients with a relapse risk of more than 40 or 45%. They're patients with a good donor, and they're fit patients with a low comorbidity score. And finally, we need to think about how we improve transplant outcomes, how we reduce relapse. And I'm firmly convinced that international collaborations with great colleagues such as those on this call are going to be pivotal as we drive forward the sort of randomized trials that are considered standard of care in the setting of intensive chemotherapy, and which are so badly needed in the setting of transplant. So I'd like to thank you for your attention. I'm very happy to take any questions.
Thank you very much, Prof. Craddock, for that very interesting and informative presentation. There are quite a few interesting questions. However, because of the time constraints, I'll just pick up 1 or 2 questions. Because I know you have answered all the questions, but most of the viewers cannot see all the answers. So one question was that about cyclophosphamide usage in AML patients, apart from the use of it in haplotransplant setting. So what are your views on it?
Yeah, I think it's a great question. Good morning, everybody. I'm only sorry that I can't be with you, and I'm hoping that when England plays Sri Lanka at an upcoming test series, we're going to do rather better than we did previously. I hope you enjoyed the IPL as much as I did, although a slightly predictable final. I think it's a very interesting new approach post-transplant cyclophosphamide. There's a smallish randomized study from Hovon that supports its use. And I think there are two critical areas of development in transplant that are going to make it more and more accessible. One is increased use of donor availability, and haplos are very promising. And the second is, how do we make transplant more effective? Reducing the risk of acute and chronic GVHD is key. So we do need randomized studies at post-transplant side, but I think it looks very promising and easy to deliver. So let's wait for those studies to roll in. And the second, as I said in the talk, is we do need to make sure that we have strategies that stop the disease coming back after transplant.
Thank you, Prof. Craddock. And one more question. This is regarding our AML patients who, in our setup, of course, we don't have the MRD assessment, the sophisticated NGS for risk assessment, risk stratification. So now your 3+7, even in the favorable group of patients, depend on the MRD assessment. So you go for 3+7, 2 cycles, and probably 2 cycles of high-dose Ara-C. But in our setup, where we don't have the MRD assessment, is it reasonable if the patient tolerates to go for 3 cycles rather than 2 cycles of high-dose Ara-C?
Yeah, I think there's good evidence that if you can't take patients to transplant and they don't have very favorable features, that you should think about 4. But there is evidence in the good risk group, you're completely right, that we may be able to manage with 3 courses. If you don't have transplant options and you don't have demonstrably good evidence of good risk disease, I think we should still be giving 4 courses of chemo in total.
Thank you very much, Prof. Craddock. Thank you very much. Your knowledge is of immense value to all of us here today. And let's move on to the next presentation. And over to you, Dr. Samatilaka.